All right. Hi, everyone. I'm here to give you your study guide for exam number 4. So basically what I did was I took apart multiple different PowerPoints from different slides, and I'm just going to basically go over those for you again. Um, this is just a resource for you, so please be sure to utilize other resources like your Taylor and Iggy and Davis Drug Guide. Assessment Made Easy is also a great resource for you to use. But for the purpose of this study guide, we're just going to go through the previously provided PowerPoints. So we started with hemoglobin. So we're going to want to make sure that we're making sure we remember our values, that males' value of hemoglobin is 12 to 16 grams per deciliter versus females' hemoglobin levels are typically around the 10 to 14 gram per deciliter range. Hemoglobin, protein found in our red blood cells that carry our oxygen. So we remember that we have carboxyhemoglobin and how that transports our oxygen and carbon dioxide appropriately to all of our organs to make sure we're maintaining tissue perfusion. So we can utilize our hemoglobin to identify if a patient has anemia. We can identify if there is a patient that might have too many red blood cells, causing our patient to have cancer, maybe related to patients having cancer, in which we'll see that polycythemia. We might see our hemoglobin change as a response to therapy. So maybe they were anemic and had received some packed red blood cells. Maybe they had a bleed and we were able to clip it or fix whatever the bleed was or the cause of the bleed was. We're going to look at hemoglobin to make sure that we know what the baseline is prior to any sort of surgeries or invasive treatments, and making sure that there is an appropriate amount of oxygen being distributed to our organs and tissues. And so we also remember that hematocrit kind of goes hand in hand with hemoglobin, and the value is 35 to 45%. We remember that the percentage is the volume of red blood cells in a whole blood sample. Again, same things that we're going to be looking at and utilizing hematocrit for: polycythemia, anemia, dietary deficiencies. Looking at a patient's hydration status may aid in calculation of our more in-depth aspects of red blood cells, determining the need for maybe a blood transfusion. So there are multiple different types of anemia. We're really going to focus just on iron deficiency, but it's important for you to be aware of the other types of anemia as well. So iron deficiency, a diminished amount of red blood cell production. There could be maybe an inadequate supply of iron or an increased demand of iron. So what are some things that could cause our patients to be anemic or iron deficiency, have iron deficiency anemia? Maybe they have some blood loss because they had a GI bleed, or maybe they had an abnormal flow of their menses. Maybe they had some sort of a trauma, ulcers, tumors, varices. So we're looking more at the esophageal varices in relation to liver function and cirrhosis. Maybe they don't have an adequate amount of intake. Really important to maintain and understand for the test the different methods of providing ourselves with oral iron. So our different food groups that provide iron. Maybe we have a malabsorption problem because we had some sort of surgical resection. Or maybe we have celiac disease or Crohn's. Aplastic anemia. So we're looking at the deficiency of bone marrow production and production of platelets, red blood cells, and white blood cells. Typically, this is a congenital deficit that occurs. Sometimes things like hepatitis, Epstein-Barr, HIV, herpes virus can cause patients to have aplastic anemia. It can be related to medications, pregnancy, chemo and radiation, and it can also be congenital. So what are we going to see in our patients that are coming in with anemia? We're going to see that fatigue, tired, um, lack of motivation to do anything, headache, muscle weakness, dizziness, lightheadedness. Sometimes you may see some palpitations. Think if our body is not being provided with the appropriate amount of oxygen, um, it can cause, our heart tries to compensate by then pumping harder. So sometimes you might see some tachycardia as well, just because our heart is trying to maintain equilibrium and homeostasis by, you know, making sure and maintaining that adequate tissue perfusion to all of our organs. So you may see patients coming in with palpitations, bruising, shortness of breath. Sometimes you may see patients coming in with a bloody nose. You may also see some dull, thinning hair. They may be pale or pallor, bruising, petechiae. They may have some blood in their stool. So again, that black tarry stool. What kind of a history do they have? Do they have a history of hemorrhage? Do they have a history of chronic renal disease? Maybe they have some bone marrow suppression related to neutropenia. And again, if we have those patients that are neutropenic, we're going to want to think about those reverse isolation precautions. So it's important for you guys to go back and really look into that and the different precautions we want to take for those patients that are neutropenic in reverse isolation. Poor nutrition, maybe they have some fluid retention causing those lab values to be diluted. Here's just a list of the different iron food groups. So again, those red meats, fortified cereals, oysters, white beans, spinach. Definitely important just to reflect back on oral iron intake. I definitely would highly suggest you guys to really look into oral iron, make a drug card on it, just so you're aware. How would you teach your patient? What's the importance that you want to teach your patient if they're taking oral iron? We want to look at health promotion and prevention. So again, reflecting back on that primary, secondary, tertiary prevention techniques. So we remember that primary is trying to prevent it from happening in the first place. So we're trying to do a lot of lifestyle modifications, weight loss, diet, exercise, smoking cessation, reduced alcohol consumption, safe sex practices, immunizations. Secondary techniques would be different types of screening. So blood pressure, cholesterol, pap smears, prostate examinations, mammograms, testicular examinations. Whereas then tertiary is patient already has a certain symptom or a situation that has occurred. So what are we going to do about it to try to make it better? So we're going to give them medications. Maybe we're going to do some medical therapy, surgical interventions, rehab, counseling, PTOT. So I did just throw in some of the rest stress adaptation slides as well, just reflecting and looking back at the PowerPoint as to remembering the different physiology, the physiological aspect of sleep. So voluntary movements, reflex movements, we're looking at our reticular activating system or our RAS. We know that our hypothalamus controls sleep-wake cycle, so it's so important to make sure that we're maintaining that appropriate sleep-wake cycle for our patients, because sometimes the lack of an appropriate sleep-wake cycle, so you have your patient sleeping all day and they're awake all night, can actually cause a lot of negative complications. We've heard of REM and non-REM. Non-rapid eye movement or non-REM, 4 stages, alternating kind of between light sleep and deep sleep stages. So just being mindful of that when we're having our patients sleeping and how we're going to maintain their quality of their care. These are just some different definitions that you should be mindful of for the exam. what is the definition of stress? What are certain stressors? How do we adapt to these situations? And then homeostasis. Important to really reflect on, um, our local adaptation system. So how we respond to pain, how we respond to inflammation related to a localized area. Whereas general adaptation system is more looking at the bigger picture and how are we acting based on stress and how does stress affect us? So that's something really important to touch base on. So again, local adaptation. So we're looking at our central nervous system response and how that's going to affect our neurologic function versus our inflammatory response. So maybe we have an injury or an infection, and how is that going to affect and promote healing process? And see how all this ends up tying together with skin and skin integrity, which is also going to be on here as well. We have our alarm reaction, which is our fight or flight response. We perceive a certain stressor and then we begin that defense mechanism. So sometimes our hormones can rise. There is a nice chart in your book that actually talks about the physiologic um, or the physical findings that you're going to see with patients with stressors. So how does it affect their heart rate? How does it affect their blood pressure? How does it affect their are they perspirating? Do their pupils, are their pupils affected by that? So I would definitely look into that as well in your Taylor book. Stage of resistance. So this is when your body tries to adapt to whatever the stressor is. So again, we're going to see some changes in those vital signs, hormone levels, and energy production. And then stage of exhaustion. So once we return to normal or the stressor dies, and it not necessarily as in a person, but whatever the stressor is that's causing your body to adjust and adapt to that stressor is no longer there and is eliminated. And how do all of these different stressors affect our Maslow, right? So our safety and our security needs, how does it affect love and belonging, self-esteem? So thinking about that and being mindful when we're looking at nursing diagnoses and how that can be affected. We have a lot of different emotional responses to stress. We utilize those posters to try to think about different coping mechanisms that we can use, support systems, reflection, meditation, exercise, um, groups, support groups is really helpful. But again, we also know that anxiety can also vary as well based on whatever the stressor is. So does it cause a patient to have some mild anxiety or are we into that panic attack? And if we're into that panic attack, how are we as nurses going to be able to alleviate that stress and anxiety? Sometimes we know that our coping mechanisms for each of us is very individualized, and my coping mechanism may differ from your coping mechanism. Um, Everyone is really different, and it's just really being mindful of what their particular coping mechanism is. So, is it appropriate for them that they laugh about maybe some bad news? Maybe they're sleeping, they're having excessive sleeping. Maybe they increase their physical activity and exercise because they know that that's helpful in releasing those endorphins. Maybe they smoke or they drink, and maybe when they do use those as coping mechanisms, we need to think about different alternatives to making sure that they're still living a really healthy lifestyle. Sometimes we have lack of eye contact, withdrawal, limited relationships. Maybe we'll deny it. You know what? I don't have this. This isn't going to happen to me. Maybe we're going to project it onto someone else. Well, I only have this because so and so or this other person suggested this for me. Um, Rationalize it, try to find the best aspect of it. Um, just get rid of it completely. Nope, I don't even know what you're talking about. I was never diagnosed with anything. Um, so there's a lot of different defense mechanisms as well when we're coping with stress. And so we have developmental stress when we're looking at growth and development. So we have to think about those um, children turning into adolescent to that young adult and how different aspects of growth and development can affect them and how do they cope with that, and is it based on what kind of a support group they have, or based on maybe their family history or their support group at home and the resources that they have available to them. Situational stress, so this typically is not a predictable item or situation that occurs. This is something that a unique situation occurs. I just got fired from my job, I just lost a loved one, I got in a motor vehicle accident. Would really explain those situational stress categories. Physiologic stress, so hypoxia, maybe you just were diagnosed with a new chronic disease. Maybe you have, maybe there's some infectious agents that could be affecting it. Psychosocial, so maybe some threats, something that's affecting your social. So really, we went back to the situational stress, these non-predictable patterns, kind of end up falling into that psychosocial period as well. And so, some different techniques that we want to be mindful of, we have relaxation, meditation. We don't always necessarily want to go right to the pharmacologic interventions. We want to think a little outside the box. What else can we provide to our patients that could be helpful for them? And we can trial and error multiple different things, but we know that pharmacologic can also have its disadvantages. So, thinking about what can be the most helpful techniques for that patient. Crisis, I did include this in here as well. You're going to learn a lot in nursing and even as a nurse about crisis interventions and how you're going to react to different situations. So I would definitely tell you to look into crisis and the different types of crisis: situational, adventitious, and maturational. So identifying whatever the problem is, listing the different alternatives, identify, okay, now I have this list of alternatives. What am I going to do about it? You're listing out those pros and cons. This is something that we do in real life situations as well. I want to buy a car. So let me weigh out the pros and the cons to buying this new car, and how do the pros outweigh the cons? And if it does, then let's go ahead and implement that plan. And then we implement the plan, and maybe 30 days out, 90 days out, we say, hey, this was a really great decision, and I was able to afford it financially, and I now have a dependable vehicle. Same thing with healthcare. Um, I'm not necessarily sure that this Taylor page number is right. I think this was from the old book, the older edition. And so it's really important just to look at how your expectations versus, which would be your ideal self, versus your real life. So, what actually do you have? What are you actually capable of being? And then comparing that and how that's going to affect your self esteem is really huge. And it's really something that we talked a lot about with those patients that come in with disabilities. And we had those posters that we talked about different scenarios that had occurred. So, this really just kind of ties it all together. And so, just moving briefly into culture, looking at dominant versus minority groups and how to differentiate and how to identify those groups. These are some of the cultural definitions I was talking about: cultural assimilation, um, values replaced by those of the dominant culture, culture shock, feelings when a person experience placed in something different. So this could even be our patients that are being admitted into subacute rehab or long-term rehab. That's such a culture shock. I've been able to be completely independent for all of my life, and now I have to live in somewhere totally different. So just thinking about that. Ethnicity, so identification with a specific cultural group, can be related to heritage, can be related to birth or characteristics of your home, your home support group. But we don't ever want to assume that a patient is a certain ethnicity or of a certain culture, because again, we never know. And I could say um, that I'm German, but it doesn't necessarily mean that I follow the German cultural techniques and values. So we don't necessarily want to assume. We want to make sure we're always assessing that first. Race, we can identify this based on certain skin pigmentations, body stature, facial features, hair texture. There are 5 major categories of race. I'm sure all of you have seen these questions in certain, um, maybe if you're purchasing something, maybe if you're trying to sign up for something on the computer, a new website or something, typically these types of questions come out. Stereotyping, it can be positive, it can be negative. So just thinking about that and making sure that you're being mindful and professional at all times. Some more cultural terminology, so cultural imposition, a belief that everyone should just conform to whatever the majority belief system is, right? And we it's not black and white, it's not, every it's gray, and our whole community and especially Albany and the capital region is so diverse, and it would be completely inappropriate to make everyone that lives in the capital region conform to one belief system. That's just impossible. Cultural blindness, you just ignore it. You're like, no, there isn't anything else. Basically, all there is, my own culture, and that's what I believe in. And I'm going to be biased now. For every patient that comes in, I'm just going to assume that they have the same cultural beliefs as myself. And we know that that's not true either. Sometimes there's some conflict, so you become aware that there are some major differences when you start to feel threatened, and you you stand up for yourself, and you start to become assertive in standing up for what your own beliefs are, and that can sometimes be inappropriate and unprofessional. You have to think about cultural influences on healthcare, like physiologic variations, reactions to pain, mental health, language, communication, family support. What are your socioeconomic factors? You can't expect someone to live in a low socioeconomic status and have the same expectations as someone with living in a higher socioeconomic status environment. So thinking about pain as well, every patient has the right to respond to pain and however they want, right? Because we remember that pain is subjective. So it's someone's opinion, and it's not something that we can stereotype. We just have to think about it a little bit more in depth. We have to think about, sometimes we'll have patients that'll come in, and maybe their significant other will answer the questions about pain related to them. And we really have to think about directly asking that patient to make sure that we're looking out for the best interest of them. So making sure you're just self-aware. We're not looking at our friends to say, hey, what do you think? How do you think I should go along with this? We really should be using evidence-based. We should be utilizing whatever chain of command that you have in whatever facility that you're working with, and really just looking back to the patient and what can I ask the patient to get the and gain the most information I can. This is again just being able to provide and understand whatever the cultural background is of each participant and every patient, and really conforming to whatever their beliefs and values are. And again, just making sure you're maintaining professionalism and being aware. So then moving into HEENT, which is something that we talked about today in lab, just really looking at all of the different assessment techniques of every system. So eyes, we have inspection, we have assessment, palpation, and we have all of our different exams that we can do. Our 6 cardinal positions of ease, we have accommodation, confrontation. So again, just looking back at that head to toe validation with comments, and that can be really helpful for you. Same thing with the ears. Again, I only pulled the one individual slide. I would definitely tell you to go back to the entire PowerPoint and really look at all of the aspects of ATENT. But for the purpose of this, I didn't want to overload with slides. So again, ears, looking at that, looking at the external ear, internal ear, making sure that there aren't any foreign bodies or obstruction. Nose, so again, nasal patency, examining the nasal cavity, making sure there isn't a deviated septum. Sinuses, frontal, maxillary, knowing where they are, how to palpate them. Mouth, throat, and neck, really important. Again, just making sure you're aware of maybe gag reflex and bad breath and odor and how that can relate to diabetes, and the assessment techniques of mouth and throat. Again, another thing we talked about today was the comparison of hyper versus hypothyroidism. So we have heat intolerance, weight loss, diarrhea, change in menses, mood changes in behavior. For hyperthyroidism, I did include this nice little picture here versus hypothyroidism, that cold intolerance, weight gain, constipation, increased frequency and flow of menses. Some extreme cases, you might see some bradycardia and dyspnea. But just being able to differentiate those, because if you do have a patient that comes in, those are some really basic generic symptoms that can trigger you to think, okay, maybe we should be testing their thyroid. Um, I'm not going to ask you any test questions about thyroid stimulating hormone lab values or anything like that. Again, we already talked about mouth and throat. Thinking about thrush and the different risk factors to thrush, how would you assess a patient that had thrush, and what are we going to do about it? We're going to give those topical antifungals, swish and swallows. We want to make sure we're maintaining good oral hygiene practices, avoiding alcohol-based mouth rinses because they can be drying. And then our neck, so just being aware of where all the different lymph nodes are, and palpating our trachea and thyroid. Again, we're not doing that for the head to toe, but again, just reflecting back and knowing the difference between symptoms of hyper and hypothyroidism. A nice picture of the lymph nodes. Last but not least, we talked about platelets today, so 145 to 450. So basically, aids in coagulation and thrombus formation. So again, if we have our patients that are on blood thinners, anticoagulants that can affect, and their platelet levels are low, that's not going to be appropriate. So just being mindful of that. Different terms, thrombocytopenia, which is a lower than normal platelet count, versus thrombocytosis, which is an increase in platelet count. And then skin, just reflecting back on our skin and how that is the first line of defense. We're going to inspect and palpate first. We're going to look at our color, our texture and turgor. We're looking at moisture. Remember, we talked about melanoma, the different signs and symptoms. So that A, B, C, D, and E. Is it asymmetrical? What's the border? What's the color? Is the diameter greater than 1/4 of an inch? And is it evolving? Different descriptors of the lesions, basically kind of what I just talked about. What's the configuration? What's the distribution? Is there any drainage? If there is drainage, what is the color? Does it have any sort of odor? Hair, again, just looking at hair loss and how that can affect, again, we're tying that back into thyroid, in addition to vitamin deficiencies and malnourishment. Again, some more definitions to look into. More definitions. And then I did just include in here the different stages of pressure ulcers as well. So just, again, reflecting back on stage 1 being non-blanchable, erythema, but our skin is always intact. Stage 2 would be maybe your skin tears or abrasions, a blister. There would never be any slough, and it would only be partially thick. And then we remember that the difference between a stage 3 and a stage 4 is that 4 is bone, muscle, tendon. They're both full thickness. Unstageable is when you're going to see that slough or eschar covering a majority of that wound. So you're not able to see the base of that skin wound bed. And then deep tissue pressure injury is that apple thrown on the floor with that nice bruise. You know, we have that purple, deep red, maroon in color. The skin is going to be intact. Sometimes it might not be intact, but you're not going to be able to see what really is going on there. And I did just throw in here the pressure ulcer prevention, support surfaces, keeping a turning schedule, and cotton skin care and nutritional assessment. So that is it for your study guide. Again, please go back and reflect on your different PowerPoint slides. Utilize your note cards, utilize all your different resources. There are a lot of resources in MESA as well. Practice questions are always helpful as well. So just try to do the best that you can with all the studying, and utilize that head to toe with that validation with comments. And if you have any questions, feel free to reach out.